Welcome to Unscripted, the AMCP podcast, a look inside managed care pharmacy.
Hello, and thank you for joining us. This episode of Unscripted, the AMCP podcast, is sponsored by AbbVie. AbbVie, where they find answers that make life better for patients in our world. And I'm today's host, Abby Kim. In today's episode, we're going to talk about ovarian cancer and the use of Elahere. So in platinum-resistant ovarian cancer, options can narrow very quickly. Patients cycle through treatments, and the question becomes, what can make a difference without adding more harm? So today, we're unpacking the clinical evidence, the evolving treatment landscape, and real-world decision-making with Dr. Kathleen Moore. Dr. Moore is Deputy Director at Fred and Pamela Buffett Cancer Center at the University of Nebraska Medical Center, and also a professor of obstetrics and gynecology at Nebraska Medicine. Welcome to the podcast, Dr. Moore.
Thank you so much for having me. I'm delighted to be here.
Yeah, so let's jump right in. And I wanted to start, Dr. Moore, by setting the clinical context. So platinum-resistant ovarian cancer remains one of the most challenging settings that we treat. So from your perspective, what are the biggest unmet needs and decision-making challenges in platinum-resistant ovarian cancer today? And how do those challenges show up in real-world practice?
You just brought up 2 points. The clinical standard, when you're thinking about a patient with recurrent ovarian cancer that you think is not appropriate for platinum, and then sort of the regulatory standard that drives how we develop medications in this space. And they overlap quite a bit, but there are also some differences. In clinical practice, of course, we think about the platinum for interval. It remains one of the most important prognostic criteria. But in and of itself, it does not tell you a tumor will or will not respond to subsequent platinum. You see a spectrum of responses, and that really comes into play with understanding the patient in front of you. What was her response to the last platinum? How many lines of therapy has she had? And what was the response to each of those? And did the tumor progress during or after that? PARP inhibitor exposure. Did the tumor progress on or after, a PARP inhibitor? Now we think about histology. In the day, in 1992, all epithelial ovarian cancer was one thing. Clear cell, endometrioid, high grade, low grade serous, all one thing. Now that's silly because molecularly these tumors are very different. So we think about the histology. We think about the molecular subtypes. Increasingly, we're thinking about the biomarkers. And the biomarker space, I think we're going to talk about this, is becoming more and more complex. In the day, there were no biomarkers. Then we had BRCA. Then we had homologous recombination deficiency. Now we have folate receptor alpha. And more recently, we have PD-L1, HER2, a myriad of other things. Those biomarkers don't exist in isolation from one another, though. So we think about the overlap and the predictive importance of that biomarker in that setting when we're selecting the next line of therapy. So it's gone from a very empiric selection of ineffective therapies, PLD, topotecan, gemcitabine, to now thinking about the science between what I select when, how I sequence things, and the safety of those drugs. It's a very different environment now.
Yeah. So I think that outlines really how far we've come to in ovarian cancer. Certainly we'll talk at the end of the podcast. We still have a ways to go, but there's been a lot of evolution over, the last couple of decades to really get drugs to the market that, are improving outcomes and improving care for patients. So let's turn to talk a little bit about Elahere or mirvetuximab. We know that it's the only, NCCN Category 1 targeted therapy recommendation in this space, so in the platinum-resistant ovarian cancer space. And it really represents a meaningful milestone. So can you walk us through the MIRASOL trial that, gained Elahere full FDA approval? And then, tell us about any key clinical data and biomarker testing, which you kind of alluded to, that supported its approval, and really what stood out to you most as clinically meaningful.
Sure. So the Elahere story, or the mirvetuximab story, I'm programmed to only use the generic name, started way back in 2011, 2012, and I was very fortunate as a phase 1 trialist to treat the first human being with this medication before it had a name in the dose escalation study, and have been involved really throughout the trajectory to FDA approval. And it's been a journey with this medication. I will say out of the gates, from dose level 3 or 4, we knew this was an active medicine, which is why those of us that do phase 1 clinical research get out of bed in the morning. You want to find these medicines that are helping patients with, heavily pretreated, whatever kind of tumor, here ovarian cancer. And we started to see, as we enrolled, especially the expansion cohorts, and got into what we felt was the right dosing range, some biomarker relationship to the magnitude of responses and the duration of responses. And that's been published. And that led to the first of the phase 3 studies. We did it again with Mirasol, just in folate receptor alpha high, went back to the original criteria by percentage and intensity, and compared it to investigator's choice chemotherapy. And that study was positive for both progression-free survival and, which was the key primary endpoint, secondary analytic endpoints were response rate and overall survival. And at the point of PFS maturity, the PFS was a hazard ratio of 0.67. So it was a 0.63, pardon me. So it was a 37% reduction in the hazard of progression events with MIRV versus chemo. At that point, there was a pre-planned interim analysis of OS, which was done. And for it to be statistically significant, it had to have a p-value of less than 0.0131. And it was. So at the interim, we were positive. And then once, we looked at it again when all the events and not surprisingly confirmed OS advantage, with a 32% reduction in the hazard of death events, or the rate of death events for those randomized to mirvetuximab. So that's the first time in the history of ovarian cancer platinum-resistant studies that we have ever shown an OS advantage. And it does show us what we can do with, modern era medications in a targeted setting.
Yeah. And that's why I think, I mentioned this is has been such a clinically meaningful drug that come to the market for ovarian cancer, and really giving patients an option in this space where, historically they haven't had many options. So thanks for laying that out for us. So we've kind of talked about the efficacy, but when we think beyond the efficacy of mirvetuximab, tolerability, and then something you've kind of touched on, like patient experience, those are critical aspects, especially in later line disease where we know these patients, their quality of life might not be as high. So, what should clinicians and then payers really understand about mirvetuximab's safety profile? And then I know we're seeing some patient-reported outcome data coming with mirvetuximab as well. So how do those factors, what does that look like, and how do those factors really influence, treatment selection?
Yeah. I'm really happy to say that the discussion around tolerability is becoming a louder discussion for our patients in the platinum-resistant setting. Again, in an era where nothing really worked well, and quite frankly, before mirvetuximab, the best regimen we had was weekly paclitaxel, which isn't a terrible regimen. I would never say that. But it's weekly, and it causes neuropathy in a pretty high percentage of patients, and hair loss. And they have to come in every week. So, and after that, nothing worked. So you sort of said, well, this is the best I have, and you can take this and the toxicity that comes with it, and I'll do the best I can to make it tolerable. Or, we use something more tolerable, but with really limited expectations of helping. What a choice, for patients. So that dialogue is changing, and I think will continue to change as more and more agents are hopefully approved. There's a lot of trials going on. Not all of them will win, but I predict that gone are the days, and I've done this. I've stood on stage and said, here's the toxicity, and it was manageable. But you really want it to be manageable for your patient, and that's tolerability. How does she stay on? How does she feel? How often is she having to be held or dose modified, or changing her behaviors because she's so tired that she can't do activities of daily living? Like, how much does this really impact what she wants to do. And that hasn't been a big part of the conversation. And we've not done a great job at that, but I think we're doing better. And we have looked at this in Mirasol. In retrospect, not in all the ways I wish I would have liked to, because I've learned a lot, but we did a pretty good job. So let's just talk about toxicity. Toxicity with mirvetuximab is a differentiated safety profile from chemo. It's not non-toxic. So we see far less hematologic toxicity, which I think is very important to say, because sometimes patients have just come off platinum-based chemotherapy or maybe something else that's hematologically toxic, and you've been on G-CSF or been dose modifying, you're kind of worried about bone marrow reserve. My experience has been we can use mirvetuximab and people actually, it works usually, and then they come off of it with kind of a break on how much we've beat up their bone marrow, and they can tolerate DNA damaging agents again. So I do think that's an important consideration when we talk about sequencing. So far less of that. We do see neuropathy. Remember, mirvetuximab's conjugated to DM4, which is a microtubule toxin. So about 22% of our population experience neuropathy. And remember, on a clinical trial, we excluded anybody with significant neuropathy. So now that it's in the wild, I'm just going to say it's probably higher. But it's less than what we see with weekly paclitaxel and occurs later. So there are some differences there. We do see nausea. And so you have to pre-medicate with this. It's not highly emetogenic, but it's moderate. And so if you pre-medicate, patients in general do quite well. But if you just sort of see what happens, they do not. And so nausea is important. About 30% of patients can have diarrhea. It tends to be very low grade and easily controlled with over-the-counter medications, as long as the patient knows to potentially expect it and jump on it right away. The biggest thing with mirvetuximab, of course, is the ocular disturbances, which in the clinical trial were about 50% of participants. And they could be a variety of things, from dry eye to blurry vision. And then the optometrist or ophthalmologist would take a look and tell us whether or not there was keratopathy. Generally, low grade, grade 1, 2. We did have a very small number of patients who had more severe ocular toxicity into the grade 3 range, which is where we see quite a bit of visual acuity disruption. But that was in the, I think 8% range, 6 to 8%. But still worth noting. We have to pay attention, and we have to follow the recommendations for every other either optometry or ophthalmologic evaluations to make sure we're keeping our patients safe. It's a nuisance for sure. Patients have to take preservative-free lubricating eye drops on a schedule and steroid eye drops. And 50% of the time we don't see anything. 50% of the time if we see it, we hold. It's mainly low grade and resolves within a week or so. And if it was really mild, we restart at the same dose, and it doesn't tend to be a recurrent thing, which is so interesting. So it's not like someone's going to have ocular disturbances the whole time they're on mirvetuximab. It happens, we mitigate, and it doesn't tend to happen again, at least thus far. I think, again, now that we have this in the wild, we're going to have to monitor as people come on with different baseline ophthalmologic diagnoses. But that's been the experience thus far, is this is reversible and is a nuisance. And I do think we have to be very clear with it up front with our patients. One of the nice things that we did, and I give credit again to the sponsor, is that we built in ophthalmologic patient-reported outcomes into the study. And I was worried about it, to be honest, because I really felt like patients were going to be very bothered by the ocular toxicities, and that it would lead to disruption in the quality of their life. And my colleague, Dr. Tashana Myers, the paper's just about out, so everyone can read it. It didn't show that. So were they bothered by it? Yes. But did it disrupt their quality of life or have any lasting impact? It doesn't appear to have. So that was very reassuring to me from a tolerability standpoint. And I think we need to just continue to be vigilant about trying to do everything we can to prevent this and help our patients, not be bothered by this. But at least by the measures we looked at, it seems that they are tolerating. The discontinuation rates because of eye tox were very low, like 2%. So I think there are messages here that it is tolerable, but we probably could be better.
Yeah. So I love that you point all of those things out. We know that the toxicity exists. We know how to provide some like proactive care to help prevent it and maybe make this more tolerable for patients. And then I love that you pointed out that the paper's coming. Just, for our listeners, watch for that paper to come out related to patient reported outcomes. I think we're always looking for more of that. And we're seeing that more, incorporated into more studies and more data. We've talked a lot today, Dr. Moore, about, just the landscape of platinum-resistant ovarian cancer, the efficacy of mirvetuximab. Now we talked about the toxicity and how to manage that. So really to close us out, let's take a look ahead. So tell us where you see Elahere heading next. How should clinicians and managed payers, think about its evolving role in ovarian cancer over time, and what should we be on the lookout for?
Thanks for that. Right now, on the global setting, we're really just trying to make sure that we have testing available in all places where mirvetuximab is potentially available, and that we're getting access to patients in the platinum-resistant setting. That's been kind of one of the big goals, is to make sure we're testing everybody, getting institutional pathways in place so that we know who our patients are who potentially would benefit from this medication, and making it available, to them in this platinum-resistant setting is the first priority. Where are we going? Well, the landscape may change in a number of ways. In the platinum-resistant setting, as I alluded to, there's so many phase 3 studies running with antibody-drug conjugates with topoisomerase payloads. Mirv has a microtubule toxin. So these are not this or this. It's that and something else. And so I would be surprised, just statistically, there's so many studies running. One of them at least is going to be positive. So I think we're going to have another set of active therapies in this setting. Some of them may be biomarker selected, some not. So that's coming. We have DNA damage inhibitors like CDK2 inhibitors, WEE1 inhibitors in the phase 3 setting, in that platinum-resistant setting as well. And we'll see if they win. I don't have any insight or knowledge, but there's some very promising agents coming in this setting that really may line up a lineup of effective things, so I never have to use PLD again in that setting, because it just doesn't work. For Mirv, though, so you might say, where does that leave Mirv? For right now, Mirv is in the platinum-resistant setting. The study that may move it up a line of therapy is called Gloriosa, which is done accruing. Gloriosa is in the first platinum-sensitive recurrent setting, and it enrolled patients with folate receptor alpha high tumors, and they got induction platinum-based chemo with bevacizumab, and then at the end of platinum-based chemo, randomized to bevacizumab maintenance, which is a standard of care in that setting, or mirvetuximab and bevacizumab. So that study's done, and it is maturing. I do not know when we will see the results. If I had to guess, I bet it's 2027, but not that long. So that's going to be a critically important study for us for a number of reasons. One, if it's positive, that would be great. Two, it's using an antibody-drug conjugate, which is targeting chemo for a long period of time, longer than we do in platinum-resistant ovarian cancer. So what sort of tolerability are we going to see in that setting? I think that's going to be very important as well. So if that's positive and tolerable, that may bump it up, and you may be using it as a maintenance therapy, and then all these other things kind of move up in the platinum-resistant setting. At the Society of Gynecologic Oncology annual meeting, which was just a few weeks ago, Dr. Gottfried Konecki from UCLA presented a study that doesn't have a fancy name. It's called Study 420. And it was also done in the platinum-sensitive setting, but it enrolled, I believe, medium and high. Double check me on that. Folate. But it gave Mirv with carboplatin. So it replaced paclitaxel. And then mirvetuximab maintenance. And it was a single-arm study just to see feasibility, toxicity, and to see if this is a direction we want to go. Do we want to try and use these antibody-drug conjugates to bump out taxane? You don't have hair loss, less neuropathy. Is it better? Is it better tolerated? Those are the questions. And that's going to need a randomized trial. But at least from a single-arm standpoint, the response rates were quite high and looked durable. And so our initial kind of take from that was, color me interested. So I think we might see that as well. And so I think that's sort of the next iteration, is moving it forward and making sure it's tolerable and efficacious for our patients.
Yeah. So I would say a lot more to watch here on this front, not only for mirvetuximab, but ovarian cancer in general. So thank you, Dr. Moore, for joining us today, sharing your expertise and your experience. We really enjoyed having you.
Thank you so much. I enjoyed talking to you.
Yeah. And thank you to our listeners for taking the time to listen to this episode of Unscripted, the AMCP podcast. Again, this episode was sponsored by AbbVie Incorporated. And for more information about AbbVie, go to abbvie.com. Thank you for joining us, and we'll see you next time.